health systems, so which suggests digital health solutions can be scaled up, they can be translated for use in different settings, different contexts, and again, there's transferability into different conditions, illnesses, and diseases. And in the context of COVID-19, why is that important? Well, these real-time remote monitoring solutions offer people a safe and secure way to engage with health services. They're driven by real-time interaction, so we understand what's happening here and now for people, help deliver optimal support, symptom management support, and importantly, support people to stay at home and stay safe, particularly if they are living with conditions that might compromise their immune system, or they have to be really careful about infection exposure and so on. And can really use digital solutions to deliver that high quality and self-care from a distance. This study was a number of partners I indicated at the start, so just to acknowledge all their hard work into this work, and just to thank you for this whistle-stop tour of some of this work, and I'd be happy to take questions, comments on email, if not today, because I do have to leave a little bit sharper than you all today. So thank you for the invitation to speak to you all today.
Thank you, Lisa, for your very interesting presentation. The discussion will be at the end. If you can stop sharing your screen, please.
Yeah, my mouse has disappeared on me. I know it. Yeah.
Yeah, that's okay. And just a moment. And we will move now to the next speaker, Professor Nadia Khan. She's an hypertension expert, and she will give a lecture about virtual management of arterial hypertension. Please, Nadia.
Thank you very much for inviting me to this talk. I'm happy to meet all of the my fellow colleagues around the world. First of all, hypertension is a really important global problem. It's the leading cause of death and disability worldwide, accounting for at least 10 million deaths annually. And it affects over 1.3 billion people or adults in the world. Despite the fact that we have available therapies, we have ability to monitor blood pressure, the majority of people around the world with hypertension do not have good blood pressure control and therefore remain at high risk for developing cardiovascular complications of hypertension. There are many reasons why hypertension is not well controlled, but many of the reasons include a lack of education, patient awareness, low engagement with health behavior change, suboptimal medication adherence, and really physician clinical inertia. So when we think about virtual care, certainly COVID-19 has accelerated virtual healthcare into the forefront of hypertension management. In fact, virtual care visits have increased 17-fold, and at least half or almost half of adults with hypertension in China, the US, and in some countries in Europe now monitor their blood pressure at home, so that they are doing quite a bit of virtual care. But most importantly, besides the fact that there is increased convenience, increased efficiencies in virtual healthcare, there's really an untapped opportunity to improve some of the barriers that I spoke about earlier in the assessment and management of hypertension. We may be able to engage patients in a more active way, provide more comprehensive assessments, and increase efficiencies that may lead to more rapid responses and accelerate blood pressure control. So today, what we're going to do in the next 8 or so minutes is to discuss 3 aspects of virtual care that may mitigate some of these barriers, and that includes monitoring, including blood pressure telemonitoring, virtual education, and digital tools for health behavior change. We're also going to touch on some of the challenges of incorporating digital health or virtual healthcare in hypertension management. So first is monitoring. Since the pandemic, there's been an increased reliance on home blood pressure monitoring. As I mentioned earlier, almost half of people in China and the US with hypertension now monitor their blood pressure at home. There are problems, however, most devices that are available on the market today have not been evaluated for accuracy. And also when patients still do have home blood pressure monitors, they often provide an insufficient number of measurements. They also selectively underreport their blood pressure readings, or in fact fail to relay their blood pressure readings to the healthcare provider. So home monitoring, which has been shown to be much more advantageous in terms of predicting cardiovascular risk and reducing misdiagnosis, really those benefits cannot be realized until we have a better way of capturing blood pressure readings. And a home blood pressure telemonitoring is actually one step beyond home self-monitoring. And it's where patients not only obtain blood pressure measurements in the home setting, but also transmit these wirelessly through Bluetooth, et cetera, to care providers, either on patient portals, through text messaging, or online. In fact, in a systematic review, home blood pressure telemonitoring was associated with a significant improvement in ability to reach blood pressure targets, particularly in high-risk patients. Telemonitoring also has a high degree of acceptance by both patients and care providers. So that is currently available. And what is also on the market are wearable cuffless devices. And these cuffless wearable devices may be promising. They offer the potential for being able to monitor blood pressure all for prolonged periods of times, allowing for circadian rhythms to be assessed, more information to be gathered. However, these devices are really in their infancy. There aren't accepted yet standards of validation, and many of these devices have not yet been validated. So they're not really at the stage where they could be used for clinical practice today, but hopefully in the future that this is a potential avenue for better blood pressure monitoring. Now, monitoring of other patient parameters is also critical. So wearable devices that collect other vital signs like ECG, blood pressure, body weight, oxygen saturation may also be able to be amalgamated in the assessment of the hypertensive patient, and including actually being able to access hospital administrative data, electronic health data, collection of omics data, genomic, proteomics, microbiome data, and all of these data sets could be curated using artificial intelligence. And that would allow us to establish a much fuller picture of patients, understand patterns and responsive to antihypertensive medications using real-world data. Now, machine learning techniques, for example, using large electronic health data sets, was actually shown to be able to predict hypertension even 1 to 2 years prior to diagnosis. So there's really an enormous potential of using AI to curate these types of data sets, advanced wearable monitors, and really improve precision medicine for hypertension management. And however, we do need more real-world clinical trial evidence on patient outcomes that this is a really effective new technique, but quite promising. Now, virtual education. The majority of physicians encourage aspects like home monitoring. However, actually, most patients do not recall ever receiving training on blood pressure measurements. And in fact, only a minority of people measure their blood pressure correctly. The public is frequently exposed online to misinformation on hypertension. And home blood pressure monitoring is much more effective if blood pressure management is also combined with patient education. So there's a real role in virtual care to optimize patient education as one of the core advances that's sorely needed. So can we optimize patient education virtually? Well, there are a multitude of digital tools, applications that provide content and video feedback, video information, et cetera, on hypertension. There is no single effective tool. Using education principles, tailoring to patients' individual needs, including two-way feedback between patients and the provider, is considered most effective. And a multitude of delivery approaches have been shown to help improve knowledge and awareness, including printed materials, telephone-based brief interactive sessions, group online education, and interactive digital tools. And these tools and interventions for education can be delivered effectively by physicians, nurses, pharmacists, and also community healthcare workers in multidisciplinary teams. And moving to digital tools for health behavior change. During the pandemic, unfortunately, with the various lockdowns, isolation, social distancing, there was an increased trend for poor quality food consumption, fast food intake, reduced level of exercise, resulting in weight gain. There was increased mental health issues, anxiety, stress, depression, sleep disturbances, unfortunately, substance abuse, alcohol consumption also increased during the pandemic. All of these have increased the risk for uncontrolled hypertension. So can telehealth and digital tools help in this arena as well? Well, certainly telehealth is feasible and practical, not just for blood pressure monitoring, but also lifestyle counseling and supporting patients' mental health. There are a multitude of software applications that can provide self-monitoring or tracking behaviors such as step counts, information sharing, goal setting, and also reminder alarms, providing feedback and enhancing patients' engagement for health behavior change. And many of these also can help with interactive and integrate with wearable data, and also provide assistance with motivation, self-efficacy, and personalized programming. Personalized interactive approaches are superior to standardized or standard lifestyle counseling for blood pressure lowering. And in fact, these types of tools and monitoring, just like what we talked about with vital signs and blood pressure, can also be integrated into clinical care practice, including through patient portals, et cetera, and can be transmitted to members of healthcare teams. And digital therapeutics may also be a promising intervention for health behavior change. Digital therapeutics is actually using personalized evidence-based apps or algorithms or combination for the treatment or prevention of medical conditions, and often are now being used to incorporate health behavior change. A recent randomized controlled trial in Japan using a digital therapeutics intervention and standardized lifestyle modification versus standardized lifestyle modification alone was associated with a significant reduction in ambulatory home and office blood pressure just at 12 weeks and even at 24 weeks. So this is a promising area for health behavior change. There are important barriers and limitations with virtual care that should be noted. Not everyone has access to broadband internet, cellular connectivity, and in rural areas, the broadband speeds could be insufficient for proper virtual interfacing. These may exacerbate or create health inequities. The cost of digital interventions and reimbursement by the healthcare systems is also quite variable throughout the world. So in conclusion, since the pandemic, virtual care delivery in hypertension will likely continue. Virtual care delivery models have to account for differences in resources, costs, infrastructures, abilities, skills, and preferences of patients and providers. But home blood pressure telemonitoring, education delivery in a virtual environment, and digital tools for health behavior change are actually effective in reducing blood pressure, enhancing adherence, and reducing clinical inertia. In the future, artificial intelligence, wearable cuffless devices may further advance our precision health for hypertension management, but larger clinical trials are needed. And of course, we need to address limitations of digital inequities. And so just to let you know that more information can be obtained from the ISH position paper, which you can use this QR code to access, and on the website for patient and provider resources, some of the education tools that I have already mentioned. Thank you very much.
Thank you, Professor Khan. That was very interesting. We'll hold questions to the discussion if that's okay. And it gives me great pleasure now to introduce Associate Professor Shariful Islam from Melbourne, Australia. And he's going to present on digital health in the management of cardiovascular and metabolic diseases. Thank you, Shariful.
Thank you, Stefano, for the invitation. It's my pleasure to present today. So I'll be talking about digital health in the management of cardiovascular and metabolic disease. Cardiovascular disease and diabetes remain the leading cause of disease burden in the world. In a recent Lancet paper analyzing the global burden of disease dataset, we showed that over the last decade, cardiovascular disease prevalence almost doubled and deaths also increased by 50%. In 2021, about 537 million adults were living with diabetes, and diabetes caused about 6.7 million deaths. Low and middle income countries remain more vulnerable to cardiometabolic disease, where the share of older persons is projected to double by 2050. In Southeast Asia, more than 1 in 2 adults living with diabetes are undiagnosed. And these numbers are also similar for patients with cardiovascular disease. When they are diagnosed, the disease has progressed quite far. Current approaches for management of cardiometabolic disease has failed to reduce the disease burden, and innovations are urgently needed to improve management. Healthcare is increasingly becoming digitalized globally and has shown to improve risk factors and disease outcome. A number of digital health technologies, including mobile health or mHealth and apps, electronic health record, telehealth, telemedicine, wearable devices, sensors, and AI and machine learning have been used. With advances in technology, digital health will likely play an increasingly prominent role in the management of disease. Our review of digital health approaches for cardiovascular disease prevention and management showed that most of the studies are preliminary studies, and as Nadia mentioned, that there is a lack of high quality randomized control trials showing the effectiveness and clinical effectiveness of these technologies in reducing cardiometabolic diseases. For over a decade, we have been conducting randomized control trials on mHealth interventions. Our mobile phone text messaging intervention in a low-income country showed that text messaging intervention helped to improve glycemic control among patients with type 2 diabetes. And the reduction was about 0.5%. In another randomized control trial in Australia, we showed that text messaging reduced depressive symptoms in patients with coronary heart disease. And we did a systematic review of all mobile phone interventions for cardiovascular disease. And we did an individual participant data meta-analysis to show that text messaging intervention reduced blood pressure and body mass index. So although these numbers were not very much, but at a population level, such intervention could be cost effective. Smartphones have also been shown as a disease screening tool, including screening for a lot of cardiovascular disease, and have been used for individuals with cardiovascular disease and their carers. We also did a systematic review of smartphone apps for diabetes medication adherence and found that there are a few apps that are really high quality and help diabetes medication adherence. So more studies are needed in this area. Web-based programs have been used to provide patient education and support disease management. However, there is a lack of low-carb dietary intervention web-based programs for people with diabetes. We conducted for the first time a parallel randomized control trial among the general community with type 2 diabetes Australia-wide and compared a web-based low-carbohydrate dietary program with standard care versus standard care alone. And at 16 weeks, we found that the intervention group participants had a greater reduction in HbA1c of 0.9% compared to the control group participants of 0.26%, with a statistically significant between group difference of 0.65% and a large effect size. Our study showed that people who used this web-based intervention had rated usability and accessibility as high, and it was quite easy to use and also appreciated by the clinicians. We conducted a recent systematic review and meta-analysis of wearable cuffless blood pressure monitoring device, and as Nadia mentioned, that these devices are not yet ready for clinical applications. We found that they had potential, but I mean, as there is no standardized guideline for validation of these devices, I mean, it still needs a lot of work. We had previously validated a wearable blood pressure device against an ambulatory blood pressure device and found that the wearable device was quite accurate in measuring blood pressure, we also developed a care platform. We are examining currently in a randomized control trial in a real-world setting whether a wearable device and care platform with individualized alerts, lifestyle change education, and clinical management will improve blood pressure in patients with uncontrolled hypertension. Another study that I'm leading is a wearable device and AI-based personalized intervention for improving cardiovascular disease outcome. So as you can see in this figure, patients who are at risk of cardiovascular disease will be provided with a wearable device, the BioBeat device, which has been approved by TGA and US FDA. And we'll also provide them with a smartphone app. So data from these devices will be transferred into a cloud-based server. And we will also extract electronic health records of these individuals in this trial and apply machine learning models and send the information to the healthcare provider to the electronic health record and a smartphone app. And the healthcare provider will use this information to provide personalized intervention, virtual communication, and remote care. The aim is to determine if we can identify blood pressure phenotypes from wearable data and evaluate the effectiveness and cost effectiveness of the WearHeart program to early detect cardiovascular disease, more specifically hypertension, atrial fibrillation, and heart failure, and improve cardiovascular risk factors. And finally, we'll evaluate the barriers and facilitators of implementing the WearHeart program in a clinical setting. Machine learning applications have been used in multiple healthcare domains. ECG is a simple and widely available tool to detect cardiac abnormalities. However, the whole potential of ECG has not yet been explored. So we evaluated if machine learning models applied to heart rate variability computed from captured ECG signals can identify people with diabetes and congestive heart failure with an acceptable accuracy. Signal processing data and feature extractions were performed using time domain analysis and machine learning algorithms. We found that using heart rate variability from ECG data, we could determine people with diabetes and cardiovascular disease from the trained model, and the accuracy was quite acceptable. It was about 0.6% for diabetes, and for congestive heart failure, it was from 8.5%. And our conclusion is that machine learning applied to ECG data can detect abnormalities that were not being suspected, early detect silent or still asymptomatic conditions, and identify individuals at risk of cardiovascular events who would otherwise go unnoticed.
Vedi. L'elettrocardiogramma non è tutto,
we have used machine learning models for cardiovascular disease risk prediction using routine clinical data. As Nadia mentioned, that electronic medical records are not very intuitive, have a lot of redundancy, are very clunky, and does not make clinicians work easier or patients' life safer. So in this study, we extracted 11,668 patients with cardiovascular disease and similar number of healthy adults from the UK Biobank data, and we used 9 machine learning algorithms for classification task and applied confusion matrix and AUC curves. So 2 machine learning models, the RBF, SVM, and GP could significantly predict cardiovascular patients. And our conclusion is that machine learning in electronic health record can make these systems more intuitive, smarter, decrease clinicians' workload, improve clinical practice, reduce variability, minimize medical error, and improve outcomes. Our next study is trying to evaluate these tools in a clinical setting in Melbourne to see whether our predictions are true or not. This is a very interesting study that we recently completed. So computer visions applied to imaging data set can identify or make new discoveries that are not easily seen by the human eye. We developed a novel coronary artery detection method based on cardiac magnetic resonance imaging. So image data were converted to numeric features and used in the nodes of the decision trees. The predictions of multiple standalone conventional neural networks were considered as input feature for the decision trees. And we used random forest and conventional neural network features for the first time on a large data set. And our method achieved excellent accuracy using the Adam optimizer compared with a standalone CNN trained using 5-fold cross-validation. These are some other papers where we used machine learning approaches for prediction of co-occurrence of diabetes and cardiovascular disease from a retrospective cohort data in Australia. We also used machine learning for prediction of cardiac autonomic neuropathy in patients with diabetes, and used machine learning approaches for predicting hypertension and its associated factors from population level data from 3 South Asian countries, and a number of other early studies where we showed that we could predict diabetes using these machine learning models. Our ultimately goal is to co-design, develop, and evaluate a smart home program to support management in people with diabetes and cardiovascular disease at home, integrating smartphones, wearable device sensors, and machine learning approaches. I would like to thank my co-investigators, my PhD students, collaborators, participants, and all the donors for supporting my research. Thank you.
Thank you, Shariful. Very, very interesting. Just a housekeeping item. Can you make sure your microphones are off during the presentations, because unfortunately it comes through. So we have the next presentation. I won't say last because it's equally as important, by Professor Philippe Rivlin on the impact of digital health in management of neurological disease. Thank you.
Can I get access to share my screen?
If you press the share screen
Yes.
down at the bottom, you should be able to. Yes.
Absolutely, it's now possible. Thank you very much for the invitation. I'm delighted to participate to this webinar. In the next 10 minutes, I'm going to primarily give you an overview of telehealth and telemedicine in neurology, because neurology is such a broad field, hundreds of diseases, some of which extremely prevalent. If we just look at the global burden of disease, you will see that whether at the world level or in high-income country, including Western Europe, we have a number of neurological disease among the top 10 condition responsible for dialysis, including, of course, Alzheimer's disease, stroke, migraine, and then there will be many others. Telemedicine has proved very useful and developing rapidly in neurology. We recently had a statement from the American Academy of Neurology on that topic, which acknowledged that during the COVID pandemic in the US, almost half of all outpatient visits were performed using telemedicine, and that it has allowed to limit the reduction in the number of such visits during the pandemic, with a smaller decline as compared to most other medical specialties. The recent survey from the American Medical Association also pointed to this situation where almost all neurologists in the US are using telehealth to some extent, and at the moment it will be for about 1/3 of outpatient visit. It's primarily used for follow-up care and also medication management, and it is clearly associated with an increased professional satisfaction. There's a number of benefits from telemedicine, which are generic, most of them. So I don't want to go into the detail. We have limited amount of time. You can read that slide. But I will insist on the fact that in neurology, we're facing a number of patients who will have limited mobility and also reduced cognitive capacity, all of which interfere with traveling and going to the hospital or to a clinic or to any kind of medical appointment. And that's really where telehealth prove very effective in our field. It's also worth distinguishing two situations. Maybe the most prevalent is that of neurological chronic condition, Alzheimer's disease, Parkinson's disease, there's a few others, but also multiple sclerosis, epilepsy, migraine, brain tumor, neuropathies, where we need to see the patient on very regular visit. And that's where adaptation of treatment, follow-up of evolution of the condition can greatly benefit from telehealth. But we have also the model of telestroke, which in fact has been developed for more than 20 years, because in stroke, as illustrated on that slide, time is brain. Every minute lost, it's 2 million neurons that are additionally compromised. So we have a number of treatment, like in cardiology, that require that we act as rapidly as possible. And in that setting, telemedicine also proved effective in reducing the time lost between onset of stroke and treatment. And it demonstrates improved mortality and also increased rate of thrombolysis. And there's also development in the field of neurorehabilitation, which is a major issue in neurology, including after stroke, but not only, to promote rehabilitation at home with a number of tools that are being developed and that will also strongly benefit from this. Yet, there has been a discussion as to whether we can perform appropriate neurological status using telemedicine. And all physicians know that the neurological assessment of a patient is supposedly one of the more complicated clinical assessment to learn and to perform appropriately. And so indeed, it's can be perceived as a challenge. But the good news is that there has been a number of studies validating performance of a neurological status using telemedicine. And I'm just showing you an overall evaluation of what has been done and its conclusion. So basically, you can appreciate most of what is important, including, of course, mental status, speech. For mental status, we have this famous MoCA that President Trump has succeeded, as you probably remember, a few years ago. But there is also one shorter version where you don't need to look at cartoon and make any kind of drawings, and it was well adapted and validated for telemedicine. You can also perform most of the examination of the motor and sensory system. You of course have to adapt your clinical examination, and same for the cerebellar examination. More difficult for what we call the deep tendon reflexes. The cranial nerve are in general also quite accessible, and there are even some mobile health tools to perform fundoscopic examination, including with some smartphone application. There are a few limitations though, so this needs to be done. They are listed here. So some tests, some neurological clinical tests cannot be performed through video conference or through the phone, but it's really a minor proportion of all clinical assessment. I will end up by saying a few more words about epilepsy, which is my specific field, and where on top of the generic telemedicine, we have a strong development in wearable device. I will say that at the moment, the main wearable that are being on the market are either tackling atrial fibrillation or hypertension or seizure detection. And seizure detection in patients with epilepsy is, of course, an important issue. Understanding that patients with epilepsy also have a number of comorbidities, most of which could also benefit from biomarkers that can be collected through wearables. We have a number of systems that can record the muscle activity, the 3D accelerometry at the wrist, the electrodermal activity also at the wrist, or the EEG in the ear or subcutaneously. Most of those solutions are in development, but some are already commercial. And this is a recent list of all what has been developed and published in the field, primarily looking at what we call generalized tonic-clonic seizure, the convulsion, and there's of course other types of epileptic seizure, but you can probably also see that only very few of those devices have been validated by either the FDA or the EC. And this is the second page of that list to show you that this is a very active field with a lot of tools being developed. Because of this development, we needed standards on how to best evaluate those new wearable devices. And this has been done a few years ago by myself and my colleagues from Denmark, Sandor Beninsky, and we have delineated now a well-accepted framework that replicate somehow what has been done in the field of pharmacological development with a different phase of clinical trials. We have also last year published the first guidelines on how such wearable for seizure detection should be developed, and that has allowed to provide some first conclusion on the topic. We are organizing every 2 years an international meeting that focus on mobile device and seizure detection in epilepsy, every 2 years in Lausanne and every 2 years in Copenhagen. And the next meeting will be in 2023 in Lausanne, and those interested are very much welcome. So in conclusion, neurology has a solid experience of the medical field and a strong interest in telehealth to manage chronic disease, to speed up the management of acute stroke. And it offers, well, the same general benefit as for all other medical conditions, but with additional value for patients with motor and cognitive limitation. We do have validated methods to perform distant neurological assessment. That's very important. And we start having validated wearables to perform chronic monitoring in epilepsy, specifically for seizure detection, and definitely a lot of opportunity for research, basic and clinical research in the field. I thank you very much for your attention.
So thank you, Philip. So now, before moving to the discussion, we will launch a short poll, and we ask you to vote for the best presentation. The best presentation will be awarded $300 and will be allowed to submit a manuscript to the journal. So just a moment, we will show you the poll, and please vote. At the end of the webinar, we will make the name of the winner. Okay, you can vote now. So I think we can move to the discussion now if everyone has voted. So if there is a question from the audience, otherwise Dr. Mihailidou and myself will make some questions. Anyone has a question? Okay, if not, I will ask a question to Nadia. The point is that in hypertension management, we know that self-blood pressure monitoring is very much working. And being involved in telemedicine and telemonitoring of hypertensive patients, a question I always have is when we should move to something more, complicated, like telemedicine and involving the doctor directly or any specific case manager. What is your opinion? Because there are contrasting opinions among experts on how to resort to telemedicine.
Yeah, certainly. That's a great question. Certainly the telemonitoring blood pressure devices are probably about 10 to 20% more costly than a regular home blood pressure monitoring device. But the issue is, we are having in the real world a lot of complications, especially with many of our patients and patient populations, with transmission of blood pressure data back to individuals. And I think that although the data showed the significant improvement in blood pressure control with telemonitoring and home blood pressure monitoring, we've seen through the pandemic the reality on a large scale implementation of home blood pressure monitoring. And I think many practitioners will agree with me that a large percentage of their population are having challenges with being able to transmit their blood pressure readings to their physician. So I think in part it's going to be on an individual basis. Some patients who will benefit from home blood pressure telemonitoring in terms of being able to transmit their data, have the capacity, the literacy to do that should be encouraged to do that currently. Physicians have found that telemonitoring actually does not increase their workflow. So from a provider perspective, it has high acceptance and little negative impact on workflow. So certainly from that perspective, telemonitoring could be used. But I think in reality, it's going to be in a phased approach with the patients that need it or can actually afford the devices and have the technology to have it transmitted to their care provider.
Thank you, Nadia. Anastasia, do you have any question?
I have questions. It's relating to all of them. It's Dr. Khan picked it up in terms of barriers. While it's wonderful to see all of this data, the reality is that it's not applicable in most settings in terms of cost, both for the equipment and for the health service. How do we get around that? Any suggestions from Nadia, Shariful, or Philippe, or even you, Stefano?
I am neutral in this case. I will not have any opinion.
Anastasia, you bring up really excellent points about barriers. And I think there's certainly digital literacy. And I think that digital literacy is something that governments, for example, we'll have to start working on. I know, for example, in Canada, because of the pandemic and the recognition that there are gross inequities by age, by race, by region, remote and rural versus urban, that the government actually is starting to implement digital health literacy improvement educational initiatives. So in terms of reimbursements, this again will have to be through government systems. And I think that societies and journals such as Connected Health and societies will have to try to promote reimbursement for doing virtual care and advocating for increased broadband services that remain so important, I think, in the future. And the public is really speaking to the fact that they want the virtual care to continue, finding more efficient. So I think the public will also play a large role in advocating for these kinds of initiatives too. Those are my thoughts. I'd certainly like to hear from others.
Khalid?
A quick word for neurology. I think number one issue is reimbursement. It's a very heterogeneous situation depending on countries, and even within the US, I'm in Europe, but I know within the US, it might well depend on the state. So especially for wearable device, because I showed you that we have some that are clinically useful, this is a very strong limitation in Europe. At the moment, there's in the US a scheme for paying for the usage of such validated and FDA-approved wearable device, but not in Europe. And so that's definitely a main issue. But in relation to this, it has an impact and it creates a vicious circle with the necessity to collect high-level, high-quality data. Because to fund good clinical trial, have appropriate sample size and so forth, you need to have a business model where investor will be keen at paying for this. And this is also failing at the moment.
Thank you. Shariful, any quick comment?
Sorry, I agree with all the comments by Nadia and Philip.
Sure.
I guess if devices become a bit used, hopefully in future we can see that the next generation of patients will be more interested in using those devices. And maybe as the devices become cheaper and more affordable, they can also buy them. And definitely reimbursement is also required.
Thank you. Stefano?
Okay, now I think we are almost done. My next task is to make a very short presentation of the journal Connected Health. You know that this webinar has been organized with the support of Connected Health and the International Society for Telemedicine and e-Health. I take the occasion to say the name of the of the contest, of the winner of the contest, and I congratulate with Professor Shariful Islam, who won the poll. So congratulations. So I will make the presentation. Jane, is fine for you if I do that?
Yes, please.
Okay, I'll do that. Okay. So, as you know, Connected Health is a young journal whose scope is to present the available evidence from research in digital health, telemedicine, including technologies and clinical studies. Connected Health is an open platform, so it's not only a journal, because as you see, we organize webinars and we have several other activities. That I will show later. The editorial board members are very important experts in the field. I have as associate editors Professor Beverly Green from USA and Dr. Miske from France. And as you see, we have very, very good editorial board members with a very long experience in telemedicine. At the moment, we have published few papers that have received a very good, that very well welcomed by the community with very good citations, downloads, and they were read by many people visiting the website. As I mentioned before, the idea of this journal is to implement not only articles, but also to provide knowledge about digital health and telemedicine. So we have talks, interviews made to most of the authors of the papers, and also we have a bulletin which is trying to provide a summary of major and most important papers and publications in the field. We very much welcome the submission of article, and let me take the occasion to thank the editorial board, but also the editorial team led by Jane Lee, because they are making a very, very good work trying to disseminate the word about this journal. So thank you. This was a very short presentation. And I think we are done, and we are almost in time, just 5 minutes later. And so I thank you, all the participants. Of course, this webinar will be available later because it has been recorded. And you can also visit the website, because you will find the recordings of the presentations of the previous webinar that I like to call the twin webinar, because it was the same webinar but focused on technical solutions. So you will be able to watch the very, very interesting presentations made by experts last time and today. Anastasia, if you want to say something.
It's a pleasure to be invited to join you to co-chair. Very exciting time for digital health telemedicine, and it's very promising to hear from all these diverse conditions that we are making headway, and hopefully our governments will support it so that we can all benefit from it. Thank you.
And thank you to Anastasia, and thank you to all the speakers for taking the time to make their very, very interesting presentations. Have a nice day and evening. Bye.
Bye.
Okay, bye. Thank you. Thank you all.
Bye.
See you.
Bye.